ส่งสไลด์เข้าไปทางอีเมลแล้วนะครับไม่รู้ว่าได้หรือยัง
ขอเช็คแป๊บนึงนะคะเรียบร้อยแล้วค่ะอาจารย์
ครับงั้นเดี๋ยวรอเพื่อนให้มาครบอีกแป๊บนึงแล้วเดี๋ยวเราเริ่มกันแล้ว
อาจารย์คะบ่ายนี้เรียนอีก2ท็อปิกหรือเปล่าคะ
เป็นใช่เป็น2 topic เป็นdeep ลงไปของ Pacemaker กับอีกอันหนึ่งจะเป็น deep ลงไปของ ICD กับ CRT ครับ
อ๋อ ถ้ามีอีกสไลด์หนึ่งรบกวนอาจารย์ส่งให้เพื่อนเลยได้ไหมคะ
ได้ครับ เดี๋ยวจะส่งให้เลย
ขอบคุณค่ะ
Okay, are you ready? I'm going to start with we will dig deep into the knowledge about the pacemaker. And I don't want you all to worry about what we are going to lecture today because some of the details and some of the terms will be complicate for the first time if you have just study about the pacemaker. But if you have any questions, please ask me. You can ask me during the lecture. It's fine for me to get it clear before the end of the lecture. Okay, so start with the topic, the basic knowledge of the pacemaker. The outline here is what you have to know about a permanent pacemaker. The first topic is about the pacing code and the mode. The second topic is pacing function. The third one is sensing function, and we will look deep into the detail of single chamber pacing and the details of dual chamber pacing. First of all, the pacing code and the mode. This is the first thing you have to know about the pacemaker. The pacing code is a generic code from North America Society of Pacing and Electrophysiology, combined with the British Pacing Electrophysiology Group. They create this code for the code is international. You can use this code to describe how the pacemaker work, and anyone who have worked in the electrophysiology field will understand what is what the pacemaker can do and what chamber it is in. So this is the first thing you have to know. The code consisted of 5 positions of letters. The first letters in the code there is represent the chamber of pacing. There are 4 types of codes. The O equal to none, V is ventricle, A is atrium, and D is dual. For the pacemaker, actually there is only 3 that it could be on the name, because you got to have a lead in either one of the ventricle or one of the atrium. You cannot have cannot have none of the lead in the ventricle or atrium. So if you put a single pacemaker in an atrium, the first code would be A. If you put only the RV lead in the ventricle, the first code would be V. And if you put the dual chamber pacemaker, which could pace on atrium and ventricle, the first chamber would be D. The second letters of the code is the sensing chamber. It represents that the pacemaker could sense from the chamber the letter represent. So if you have V in the second letter, that means the pacemaker would sense intrinsic rhythm from ventricle. If you have A in the second letter, it would represent the pacemaker could sense the intrinsic rhythm from the atrium. And for the dual chamber pacemaker, the pacemaker could sense intrinsic rhythm from both ventricle. We should use the word D. So we have first letter for chamber that could be paced, second letter for chamber that could be sensed, and the third letter is the response to sensing. This is to describe this is the action of the pacemaker. What pacemaker will do when it senses the intrinsic rhythm. There is 3 letters. The O equal to none. I is inhibit. and T is trigger. None is the pacemaker could sense, but the pacemaker won't do anything to the sensing they see. I is when the pacemaker sends intrinsic rhythm from the heart, it inhibits itself not to fire the pace out of the machine. For example, if you have single chamber pacemaker VVI that could pace from V, sense from V ventricle, and if you have intrinsic rhythm from V coming to the leads and pacemaker could sense that, the pacemaker would inhibit itself not to fire a pacing spike out of the generator. And another letter in the third code is T. T is trigger. Trigger is opposite than the inhibit. It means that if the pacemaker sends the intrinsic rhythm, it would trigger itself to initiate the impulse and pace the patient. And the last one is D. D the D is dual. Pacemaker have both response to sensing to it. It could inhibit itself and it could also trigger itself after it sends the intrinsic rhythm. I will have the example in the next two slides, so don't be worried just yet in this moment. The fourth letter is Red Modulator. This is the function in which pacemaker could control the rate according to the activity of the patients. They can use a lot of indicators to indicate that the patient who were implanted with pacemaker are moving, are exercising, or at rest. If the patient is exercising, they require higher heart rate. So the rate modulator will increase the rate of pacing by itself. This code, if the patient was programmed with this rate modulator, the code would appear and are letters in the fourth letter of the code. If the patient do not have rate modulator, there it should be 0 or there should be any code on the fourth letter. And number 5 is multi-site sensing. Multi-site sensing is a function that in one lead there are multiple electrodes that could sense from different parts of the heart. For example, if you have multi-site sensing in ventricle, you could sense from different parts of ventricle, like 3 or 4 sites. This would represent the fifth code of the pacemaker, but we don't usually use the fifth code. In clinical practice, we usually use only 3 to 4 codes to describe pacemaker, because most of the pacemaker do not use multi-site sensing. Okay, so this is the first example. Can anyone tell me what this pacemaker is? Which chamber is this pacemaker is pacing?
Dual chamber.
Okay, it's dual chamber. So the first letter should be D, because this pacemaker can pace both from atrium and ventricle. And usually if you put the lead in, if the pacemaker can pace both atrium and ventricle, it usually can sense from both leads. So the second letter should be D. And the third letter is that it should you have to see if the pacemaker is inhibit or trigger after it sees the intrinsic rhythm. But in this case, the it might be hard to understand. But if the dual chamber pacemaker, the ventricular leads can respond to intrinsic from the atrial leads. So if there is an impulse from atrium traveling down to the ventricle will see the impulse, and it could both inhibit or trigger. If you program the pacemaker to the third chord to D, it would track the rhythm from atrium, and if the intrinsic from the ventricle is not coming, it would pace. But if the intrinsic is coming, the pacemaker would inhibit itself, the ventricular lead would inhibit itself and not pacing, and let the intrinsic come out. This one is pacing from both ventricle, and it's also sensing from both ventricle, and it responds to sensing by, this one is respond to sensing by trigger, because it triggers after the intrinsic of atrium. What about this one? Which chamber is the first letter? Can anyone answer the first letter?
Dual.
Okay, the first letter is dual. And the second letter?
Dual.
Okay. You can see that it could pace both on atrium and ventricle, so it's dual pacing. And it could, if you see this one you can see that the beat before this one, you have an atrial spike pacing, but the next beat you don't have the atrial spike pacing. This means that the A leads could sense the intrinsic P wave. So you know that there is a sensing in atrium. And if you look at this one is pace, but this one before, there is no pacing spike on okay, sorry, the ventricle is pacing, but as I said before, if you could pace from both ventricle and atrium, so you could sense from the same lead. So it's the second letter should be dual also. But the difference between this ECG and the last ECG I've shown you is that there is no tracking of the P wave and QRS. The A to B, the P wave, and to R wave, the PR segments is not constant. You can see that there is this one PR is short, but this one PR is not constant. So the pacemaker is not tracking the ventricle is not tracking the atrium. So the ventricle is this function should be inhibit only because it could not the ventricular signal could not be triggered after it sends the P wave. If it is dual in the third letter, it sees this P wave, it should trigger itself to pace ventricle with a constant PR. But this pacemaker could not trigger itself to pace in this moment. So there shouldn't be any trigger function in this pacemaker. But the pacemaker could inhibit itself if it sees the intrinsic rhythm. So this one is dual pacing, dual sensing, but the response to sensing is inhibit. For this one ครับผม
คือเป็น dual ใช่ไหมคะแต่
เป็น
ว่าไม่
dual
แต่
แต่
ว่า
ว่า
inhibit อย่างเดียว
ใช่ เพราะว่าปกติอะถ้ามันถ้ามันมีทริกเกอร์เวลามันเห็นสัญญาณของเอเทรียมที่ไหลลงมาแล้วมันทิ้งไประยะหนึ่งแล้วอินทรินซิกไม่มามันต้องทริกเกอร์ตัวเองให้มันเพสขึ้นมาได้แต่อันเนี้ยคือพอมันเห็นตัว P wave ที่ไหลลงมาถึงระยะเวลาหนึ่งแล้วมันไม่มีอินทรินซิกมันไม่ได้ทริกเกอร์ตาม P wave ตรงเนี้ยแต่ว่ามันเพสออกมาตามเวลาที่เราตั้งขึ้นมาถ้าสังเกตดูอะจะเห็นว่า RR interval ตรงเนี้ยมันเท่ากันหมดเลยอันเนี้ยกับอันเนี้ยมันเท่ากันถูกไหมเราตั้งเรทของ ventricle เรทหนึ่งมันก็เพสของมันไปไม่สนใจเราตั้งเรทของ atrium อันหนึ่งมันก็เพสของมันไปถ้ามันเป็น dual ถ้าตัวที่3อะ response to sensing มันเป็น dual อะมันต้อง track กันตัวนี้มี intrinsic มาเราตั้ง AV interval ไว้อีกค่าหนึ่งถ้ามันเกินค่านั้น intrinsic ไม่มามันก็จะเพส vertical ขึ้นมาเพราะฉะนั้น PR interval มันจะต้อง constant ซึ่งอันเนี้ยพอ PR มันไม่ constant ปุ๊บมันก็เลยจะไม่ใช่ response to sensing ที่เป็น dual อันนี้เข้าใจไหมค่อนข้างยากนะ
ใช่ค่ะ
เดี๋ยวลองดูไปก่อนso what about this one which chamber is the leads in anyone know if nobody knows I will answer it to you you have seen this pace spike in front of the QRS so it should be there should be a lead in the ventricle definitely there is a V but how can you know that there is a lead in the atrium or not? You should look for the P wave. If there is pace spike in front of P wave, you know that there must be the atrial lead. But in this case, there is no pace spike in the atrium. So you need to see if the atrium is sensed or not. But how can you do that? If the atrium is sensed, it should inhibit the pacing. Is that correct? So in this ECG, there is P wave in here and here. There is no spike, but from this ECG, we could not tell that there is atrium leads or not, because if there is we could not know that if the atrial lead is sensing from this P wave or not. So from this ECG, it can be it could be only V leads, or it could be both on A leads and V leads. Could be V or D. So so the next letter is the same. There's a V lead, so there's sensing of V also. And the sensing of A is could be V, only V, or could be D. But the next thing we know for sure is that the PR interval is not constant. It's not tracking each other. The atrium and ventricle is not tracking each other. So from this ECG, the third letter should be I. For the answer from this ECG, it should be VVI or the DDI. Do you have any questions regarding of this ECG? You can ask in Thai. It's quite confusing if you are the first time to see this.
อาจารย์อธิบายอีกทีได้ไหมคะ
ได้เดี๋ยวเป็นภาษาไทยก็ได้ครับ คืออย่างนี้คือเวลาเราดู EKG เราต้องรู้ก่อนอย่างแรกว่าสายมันอยู่แชมเบอร์ไหนถูกไหมแล้วก็พอรู้ว่าสายอยู่แชมเบอร์ไหนเนี่ยเราก็จะรู้ได้ว่ามันเพสจากไหนได้ V จากไหนได้ถ้าเราสมมุติเราดูตัวแรกดู pacing ก่อนที่รู้แน่ๆคือคนเนี้ยมีสาย V แน่ๆเพราะว่าเขา pace V ถูกไหมทีนี้มันมีสาย A หรือเปล่า pacing A เนี่ยมันไม่เห็นเพราะฉะนั้นเราบอกไม่ได้ว่ามันมีสาย A อยู่หรือเปล่าดังนั้นเนี่ยพอเราดู pacing ของดู pacing ไม่ได้แล้วเนี่ยเราก็ต้องไปดูตัวต่อมาก็คือดู sensing ว่ามันสามารถเซนส์อะไรได้บ้างซึ่งแน่ๆแหละคนเนี้ยมีเซนส์ V แน่ๆเพราะว่าเขามีสาย V อยู่ทีนี้สาย A เนี่ยจะดูได้ยังไงเราก็ต้องดูหา P wave ใน ECG ว่ามันมี P wave อยู่ไหมก็คือคนนี้พอหา P wave แล้วมันมี P wave อยู่2ตัวนี้ที่วงเอาไว้ P wave เนี่ยมันเป็น Intrinsic Rhythm อันเนี้ยมันอาจจะแปลว่าเครื่องมันเห็นแล้วมันไม่เพสก็ได้ถ้าเป็นกรณีนั้นแสดงว่ามันมีสาย A อยู่ด้วยเพราะฉะนั้นมันก็ควรจะเป็น Dual Chamber ก็ควรจะเป็น DDI แต่ว่าจริงๆแล้วเนี่ยมันอาจจะไม่ได้มีสาย A ที่มันเซนส์อยู่เลยก็ได้มันอาจจะเป็น Intrinsic Rhythm ที่มันไม่มีสาย A แล้วมันก็เต้นมั่วของมันอยู่เลยก็ได้ถ้ากรณีนั้นเป็นได้ก็คือมันมีแค่สาย V อย่างเดียวก็คือมีแค่ V pace แล้วก็ V sense ทีนี้เนี่ยมาดูตัวที่3ก็คือเป็น inhibit trigger หรือ dual ถูกไหมของคนไข้คนเนี้ย PR มันไม่ constant มันไม่แท็กกันถ้ามันไม่แท็กกันเลยเนี่ยแสดงว่ามันไม่น่าจะมีฟังก์ชันของ trigger ที่ P wave ลงมา trigger ตัว ventricle ทำให้ pace ได้มันน่าจะมีแค่ inhibit function ก็คือมี I หรือว่าเป็นอีกกรณีหนึ่งเลยนะก็คือตัวที่3เนี่ยไม่มีฟังก์ชันอะไรเลยก็คือมันเพสอย่างเดียวเลยไม่สนใจเลยก็คือไม่สามารถ respond to sensing ได้ก็คือเป็นตัว O ก็คือเพสอย่างเดียวอันนี้ก็เป็นกรณีที่3ได้ก็คือเป็น VVO หรือ DDO ก็ได้จาก EKG เนี้ยนะเป็นได้4อันเลย เข้าใจไหมหรือให้เอาใหม่อีกที
เข้าใจแล้วค่ะ
เดี๋ยวมีกลับไปใหม่เดี๋ยว I have slightly similar ECG at the back of this lecture, and you can answer me at that time, and I could see that you are understand it or not. Quite hard because my fellow and my resident at the hospital still confusing about this topic. Just take your time, it's okay. Okay, the next thing you need to know about the pacemaker is how to calculate the rate and interval of patient heart rate. It's quite similar to the surface ECG. The standard speed was 25 millimeter per second. The 25 millimeters is equal to 1 second. The 5 millimeters is equal to 1 large box is 0.2 second or 200 milliseconds. And for the 1 millimeter is one small box is 40 milliseconds. The cycle length or the cycle length is the RR interval in the millisecond unit. If you want to calculate the rate, it is in one minute. Is 1 minute subtract to the cycle length? It is 1,500 subtract to small box, or 300 subtract to large box, or you could use 60,000 subtract to millisecond. We usually use this one, the last one, 60,000 subtract to milliseconds in the clinical practice, and we use the 300 subtract to large box in the surface ECG. But if you have the cycle length in milliseconds, you use the last sentence, the 60,000 subtract to the cycle length millisecond. So ครับ
Is it 60,000 divided by millisecond?
Yeah, sorry, it's divided. Sorry, I used the wrong word. It's divided. It's all divided. Sorry. So sorry. I said the wrong word. It's divided. Okay, so let's do this. If you have a patient who have a cycle length of 600 milliseconds, what would be the rate of the patient? Here, if you have a cycle length of 600 milliseconds, so you use 60,000 to divide the 6300. So the patient would have the rate of 100 beats per minute. And if you use the rate and divided 60,000 divided by the rate, you could convert it back to the cycle length in millisecond. So now I am going to explain about the fourth code of the pacemaker, the rate modulation. This rate modulation it is used to help patient vary the pacemaker rate to respond to their activity. So how the pacemaker know that the patient has some activity? There must be a sense parameter, or there must be some indicators in the pacemaker to respond to this function. The first one is the response to the patient movement. The pacemaker would have the accelerometer sensors, which is a type of sensors. It will be notified if the patients have moved their chest wall or moved their bodies, and that if that movement occurs, the pacemaker would pace at the high. higher rate. The second one that can be response is the respiratory rate. Some types of pacemaker have an indicator that would respond to a faster respiratory rate and slower respiratory rate. If there is a faster respiratory rate, the pacemaker would assume that patient is doing some activities, so the pacemaker would pace more frequent. Also, there is a parameter that measure the change in T wave in the intraconnect electrogram of the pacemaker. If the P wave have changed their morphology, the pacemaker would pace faster or slower. There's a new type of sensing parameter nowadays. Some of the pacemaker could sense the activity of your heart or your body by increase or decreasing the impedance of the blood in the chamber, or sometimes could sense the temperature from the chamber. These parameters or these indicators are different between the new type of pacemaker and different across the companies who manufactured these pacemakers. Okay, so it came into the first function of the pacemaker that it is very essential, the pacing function. There is term that you need to know. The first term is capture. Capture is be used when there's a pacing spike that causes depolarizations and contraction of the heart. Capture mean that the pacemaker fire the power, the electrical out, and this electrical capture the myocardium and induce the depolarization and leads to contraction of the heart. This capture, if the pacemaker is not captured, it called capture to failure to capture or loss of capture. We could observe this phenomenon by the ECG. This is the ECG of the pacemaker that is successfully captured the myocardium. You can see that there is a pacing spike in front of the QRS. Every pacing spike there is a QRS followed by, and also in the atrium pacing, there's a pacing spike and there's a P wave follow the pacing. The second word is capture threshold. The capture threshold is the lowest amount of energy required to produce a depolarization or to produce a contraction of a heart. It for example, if you put a pacemaker in a patient and you pace from 5 millivolt, then it capture. You pace to 4 millivolt, it's also capture. But you pace to 3 millivolt, the pacemaker does not capture the myocardium. So the capture threshold would be 4 millivolt. There's two components of stimuli. There's a pulse amplitude, which the unit is volt, and the pulse duration, in which the unit is millisecond. This is a two component of capture. The capture threshold may be called, if you were used in the clinic, they may call it pacing threshold or stimulation threshold. The capture threshold of the ventricle and atrium that should be programmed. In the atrium, in the acute phase, it should be more than 1.5, and the ventricle in the acute phase should be more than 1. And in the chronic phase, both should be more than 2.5 volt. The safety margin of the threshold, if you program the pacemaker, it should be around 2:1 or 3:1. For example, if you have a pacing threshold of ventricle at 0.8, for the safety of the patient, you should program the pacemaker to pace at around more than 1.6 volt to gain the safety margin, because if there is some failure of system, if there is some fracture of the lead, pacing threshold might be increased more than 0.8, and that would cause a problem if you program the pacemaker output too low. Anyone have any question about this capture threshold?
อาจารย์อธิบายอีกรอบได้ไหมคะ
ได้ครับ เอาตั้งแต่อันแรกเลยไหม
แค่หน้าเมื่อกี้ก็ได้ค่ะ
อันนี้ใช่ไหม
ใช่ค่ะ
คืออันนี้คือเป็นการตั้งเอาใหม่บอกว่า capture threshold is the lowest energy required to depolarize the myocardium, but when we program the pacemaker, we program the output of the pacemaker to be higher than the capture threshold, so that pacemaker could pace. But we don't usually program the same level as the capture threshold, because if the threshold gets higher, there must be some problem with the pacemaker and it could not be paced. คือประมาณว่าถ้าสมมุติว่า pacing threshold มันอยู่ที่สมมติอยู่ที่1อย่างเงี้ยเราก็จะไม่ได้ตั้งไว้ที่1เลยไม่ตั้ง output ไม่ตั้งเครื่องไว้ที่1เราก็จะตั้งเครื่องให้มันสูงกว่านั้นประมาณ2เท่าเพื่อให้มันมี safety margin ว่าถ้าเกิดมันเกิด lead มันหักหรือว่า lead มันมีปัญหายังไงเนี่ยมันจะได้มี space ที่เครื่องมันยัง pace ได้อยู่เพราะว่าเราตั้ง output ไปสูงกว่านั้นมันจะมี2คำมันจะมี threshold capture threshold คือ output ที่ต่ำที่สุดที่จะ pace ได้แล้วก็มีโปรแกรม output ก็คือโปรแกรมว่าจะให้ใช้พลังงานเท่าเนี้ยสมมุติใช้พลังงาน2อะเพื่อที่จะ pace คนไข้เราก็จะตั้งไว้สูงกว่าประมาณ2เท่าทีนี้ถ้าสมมุติว่าไอ้ตารางเนี้ยก็คือ capture threshold ในช่วง acute ก็คือช่วงที่เพิ่งใส่ใหม่ๆอะของ atrium กับ ventricle มันควรจะมากกว่า 1.5 แต่พอเวลาผ่านไปอะเหมือนคาบที่แล้วที่โชว์ให้ดูอะว่าบางทีมันมี fibrous มีอะไรมาเกาะที่ปลายสายพอเวลาผ่านไปนานๆเนี่ยพอมี fibrous มีปลายสายเพิ่มขึ้นเนี่ยมันก็จะไม่ได้มันก็ต้องใช้ energy มากขึ้นเพราะว่ามันมีตัวมาเกาะไม่ให้โดน myocardium อะเพราะฉะนั้น pacing threshold มันก็จะสูงขึ้นตามระยะเวลาซึ่งถ้ามันสูงขึ้นได้มากกว่า 2.5 มันเป็นค่าที่สูงขึ้นที่รับได้โอเคนะ
ขอบคุณค่ะ
Okay, another the second terminology you have to know is pacing spike on pace ECG. Pacing spike or pacing artifact, it is a straight line. It's a straight line that could show you that the patient rhythm now is from the pacing. The pacing spike, if the pacing spike is higher, it's because sometimes you put more energy in, you set the output higher than before, the pacing spike might become bigger. And if you put the energy lower and lower, the pacing spike might become smaller. And in the unipolar pacing, the pacing spike is likely to be bigger than in the bipolar pacing, because the unipolar pacing use more area of pace. The cathode node is in the tip, and the anode node is on the pulse generator. So it takes more area of pacing. That result in a bigger pacing spike. This has to be careful, because in a modern pacemaker which use the bipolar pacing, some of the pacemaker have a relatively slow pacing spike. You might not identify some from the ECG. So when you understand the pacing spike on the pace ECG, the ECG below is there are pacing spikes before the QRS complex. So this is we call ventricular pace or V pace. And if there is no pacing spike before the intrinsic, like this one, there is no pacing spike on the atrium on the P wave. This might be atrial sensing. The ECG of the pacemaker, there is two events. The first one called intrinsic event. The intrinsic event is the intrinsic atrial or ventricle signal. The pace event is the pace before P wave or QRS or atrial or ventricle pacing. This should have a pace spike before the P wave or the QRS. If the intrinsic rhythm come, sorry, before I have talked about this, this is the dual chamber pacemaker. We assume that the patient is implanted with the dual chamber pacemaker. So the patient has the atrial channel and the patient has the ventricular channel. So if the intrinsic come, there is an intrinsic P wave. The atrial channel would sense the P wave, and it would call a sense. If there is intrinsic ventricular wave, the ventricular sense signal, it would call the V sense. But if there is no intrinsic in atrial channel, the atrial have to pace, it called a pace. There should be a spike before the P wave. And if the ventricular channel cannot sense anything, it would pace. There is a spike before the QRS complex. It would call V pace. The morphology of the ECG appears on the ECG depends on the site of stimulation. And also we could see the capture that there's a pace spike and followed by QRS in the ECG. This would call the capture, that as I mentioned before. So can you describe this one? You see the spike here. Anyone can answer me for this the ECG?
Like no P wave.
No P wave, or no, there is a spike, but I don't think it capture anything. So this one is failure to capture. And you see this one. This one is failure to capture. This could cause by the failure of capture can be caused by a lot of etiology. Maybe you program the output pacemaker too low, and there is only weak stimulus, so it could not capture the ventricle or the atrium, or there's some increased stimulus threshold from the lead failure or from the myocardium. So this is failure to capture. What about this one? What do you see?
I think it is capture.
You see it's capture, right? Here is capture. But why did the QRS complex morphology is different between this one and this one? And can you see there is some pacing spike here in the QRS complex? It means that if the pacemaker sees the QRS, which the pacemaker see, we could use the sense word. If the pacemaker could sense the QRS, this one, it should not pace here. Is that correct? And this one is intrinsic beat. 2 and 5 is intrinsic beat. The first one and the second one is capture beat. You are correct. The third one and the sixth one is fusion beat. The fusion beats mean that there is some part of the QRS from pacing and some part of the intrinsic. It fused into together, so it results in another morphology of QRS. This one called fusion beats. And the fourth one, the morphology is the same as the intrinsic QRS, but there's a pace spike on top of it. It's called pseudo fusion on the fourth beat. This one may caused by an abnormal sensing because the pacemaker could not see the QRS that is coming, so it paced into the QRS. Do you understand this one? I could speak it again if anyone want me to.
อาจารย์อธิบายอีกรอบได้ไหมคะ
ได้ครับ
ขอบคุณค่ะ
อันนี้เพสนะเพสแล้วแคปเจอร์เพสอย่างเดียวหน้าตามันก็เป็นตัวกว้างๆก็คือ1กับ7คือเพสแล้วแคปเจอร์ธรรมดาตัวที่2กับตัวที่5เนี่ยคือ intrinsic ของคนไข้ก็คือตัวแคบๆถูกไหมตัวที่3อันเนี้ยมันเกิดจากการที่มันเพสมาพอดีแล้ว intrinsic ก็มาพอดีมันเลยตกรวมกันเป็นหน้าตาลูกผสมระหว่าง1กับ2เขาเรียกว่า fusion beat อันนี้เป็นคำที่ต้องรู้ว่าอันนี้เรียกว่า fusion ส่วนคำที่3เนี่ยไอตัวที่4เนี่ยก็คือมันหน้าตาเหมือน QRS ปกติเลยนี่แหละแต่มันมี pacing spike มาตกพอดีแต่ว่ามันมาตกใน QRS complex มันอยู่ใน refractory period ของ heart อ่ะมันก็เลยไม่ pace อันนี้เรียกว่า pseudo fusion ก็คือมันมี pace มาตกจริงแต่เพสไม่ติดอ่ะมันก็เลยหน้าตายังเหมือนกับ intrinsic beat อยู่เขาก็จะเรียกว่า pseudo fusion คือเหมือนเป็น fusion ปลอมๆคือถ้า fusion จริงๆมันต้องมีทั้งเพสที่เพสติดบวกกับ intrinsic ของมันซึ่งจริงๆอันนี้มันเป็นปรากฏการณ์ที่มันไม่ควรจะเกิดขึ้นเพราะว่า pacemaker มันควรจะเซนส์ intrinsic แล้วก็พอมันเซนส์ intrinsic ได้เนี่ยเพสไปมันไม่ควรจะเพสขึ้นมาตรงเนี้ยมันมีโอกาสเกิดจากเซนซิงที่เสียเหมือนกันเดี๋ยวพูดต่อไปthis is a description of the fusion beat. Pacing spike is delivered at precisely the moment the heart was going to beat on its own. Good. It is the combination of capture beat plus intrinsic beat. So it represents in a new morphology, which is some kind of combination of two of these together. It looks like a cross between a repacing and resensing beat. Here, number 3 and number 6. Pseudo fusion beat. It's a beat. Number 4 is a pacing spike collide with intrinsic depolarization. The morphology of the pseudo fusion is the same as intrinsic beat, but there's a pace spike on it, and the output has no effect of the heart. There is no capture. Only the pace spike is on the QRS complex. Everyone clear about these terms? Okay, if there's no question, I would go further to the sensing function. The second function that is important is sensing function. Sensing function is what the pacemaker sees from the intrinsic rhythm. It's called sensitivity of the pacemaker. There is 2 words you need to know, you need to understand. The undersensing, the oversensing. And another 2 words that is important is increased sensitivity and decreased sensitivity. This might be these 2 words. People confuse a lot about these 2 words, but I will explain it slowly to you. As I said before, sensing refers to pacemaker's ability to see the intrinsic cardiac activity, and if appropriate, to respond to it. This graph shows the sensing function. In the y plane of the sensing function is the sense R wave amplitude. The amplitude of R wave that could be sensed, the higher the amplitude, the more the pacemaker could see. It means that if you are in the ventricle, you should see the R wave on the ECG. And if the number of the sense R wave amplitude is high, like if it is 7 millivolt, compared to pacemaker that could sense the R wave 2 millivolt, the 7 millivolt is called better sensing because the pacemaker could see the same R wave, but the first one see it's bigger than the second one. What to say? Anyone have questions about this? อันนี้เข้าใจใช่ไหมครับ
ขอเป็นภาษาไทยอีกรอบได้ไหม
ได้
คะ
ก็คือ sensing คือเครื่องมองเห็นสัญญาณของหัวใจถูกไหม เราก็จะมีตัวเลขที่เขาเรียกว่า sense amplitude เพื่อบอกว่าเครื่องเนี่ยมันเห็นสัญญาณได้ใหญ่หรือมันเล็ก ยิ่ง sense amplitude เยอะแสดงว่าเครื่องมันเห็นสัญญาณได้ตัวใหญ่ sense amplitude เล็กแสดงว่าเครื่องเห็นสัญญาณได้ตัวเล็ก ถ้าสมมุติว่าคนหนึ่งเราใส่ pacemaker เข้าไปแล้วมัน sense amplitude ของ R wave เนี่ยมันได้10เทียบกับอีกคนหนึ่งที่ใส่ pacemaker เข้าไปแล้ว sense amplitude ของ R wave ได้แค่3แสดงว่าคนที่ sense amplitude ได้10sensing ดีกว่าคนที่ sense amplitude ได้3เพราะว่าใส่เครื่องเข้าไปเหมือนกันเดะเลยแต่ว่าเครื่องมันเห็น R wave ตัวใหญ่กว่าเข้าใจไหม
เข้าใจค่ะ ขอบคุณค่ะอาจารย์
โอเค
เซนส์แค่
มันเซ็นได้ทั้งคู่ครับมันเซ็นได้ทั้ง R wave แล้วก็ P wave แต่อันนี้ยกตัวอย่างแค่ R wave ก่อน ก็คือถ้าก็เหมือนกันถ้าเกิดสมมุติว่ามัน sense P wave อย่างเงี้ย ส่วนใหญ่แล้วค่า normal เวลาเซนส์ของ P wave มันต้องเล็กกว่า R wave อยู่แล้วถูกไหมเพราะว่าใน EKG อ่ะ P wave มันก็ตัวเล็กกว่า R wave ใน P wave เนี่ยสมมุติว่าคนเรา sense amplitude ของ P wave เนี่ยได้สมมุติได้3เทียบกับ sense amplitude ของP wave ได้1อันที่ได้3ก็คือ sensing function ดีกว่าอันที่ได้1โอเคนะ
โอเคค่ะอาจารย์ขอบคุณค่ะ
There is another word. This is sensing function. This sensing function. There is another word when we program the pacemaker. We would use the word sensitivity set. เดี๋ยวอธิบายภาษาไทยก็ได้ก็คือสมมุติว่าเราเห็นสมมุติว่าสมมุติเราใส่ ventricular นะอยู่สาย ventricle นะแล้ว R wave sensing เนี่ยได้สมมุติว่าได้5มันเห็นได้5แต่ว่าเราจะตั้ง sensing ของเครื่องให้อยู่ประมาณ3เพราะว่าถ้าเราตั้งสูงเกินไปมันก็จะไม่เห็นintrinsic rhythm ให้นึกภาพว่าเวลาเราตั้ง sensitivity setting เนี่ยเราตั้งเป็นกำแพงขึ้นมาสมมุติว่าถ้าเราตั้งกำแพงที่สูงเกินไปสมมุติว่าตั้งขึ้นมาเส้นแดงเนี้ยเครื่องมันก็จะมองข้ามกำแพงไปแล้วมันก็จะไม่เห็นpace ไม่เห็น intrinsic rhythm แต่ถ้าสมมุติว่าเราตั้งกำแพงให้มันต่ำลงมาหน่อยให้มันต่ำกว่าตัวเลขของเราเนี่ยเครื่องมันก็ยังจะเห็น intrinsic rhythm ได้อันนี้เข้าใจไหมเวลาเราตั้ง sensitivity คือเราต้องตั้ง sensitivity setting ให้พอดีไม่สูงเกินไปไม่ต่ำเกินไปเพราะว่าถ้าสมมุติว่าเราตั้ง sensitivity setting ต่ำเกินไปอย่างเงี้ยแล้วเกิดคนไข้เนี่ยไปมี activity แล้วมี noise มี electronic noise ที่มันเข้ามากวน pacemaker แล้วปรากฏว่า noise มันขึ้นมาสูงกว่า sensitivity ที่เราตั้งไว้เครื่องมันจะเข้าใจผิดนึกว่า noise เป็น intrinsic rhythm แล้วเครื่องมันก็จะไม่ไม่ทำงานคนไข้ก็จะมีปัญหาได้เพราะฉะนั้นเวลาเราตั้ง sensitivity setting เนี่ยเราก็จะตั้งให้พอดีอยู่ประมาณกลางๆไม่ตั้งสูงเกินไปหรือไม่ตั้งต่ำเกินไปเข้าใจไหมครับอันนี้โอเคเนาะIs there anyone in the class who don't understand Thai?
Yes อาจารย์
มีใช่ไหมครับ Okay. Okay. I will explain it again in English. There's the first thing that I talk about is the R wave amplitude. The R wave amplitude. This is the example that we put the RV lead into the ventricle, and so I use the R wave instead. It's the same if you put the leads into the atrium. I would use the sense P wave amplitude. If there is if the pacemaker we put in and the patient has the R wave amplitude of 10 comparing to R wave amplitude of 3, the patient who has R wave amplitude of 10 millivolts has a better sensing function because the pacemaker could see the intrinsic rhythm better. They could see a bigger one than a small one. And this is the first step to understanding the sensing function. And for the setting of the pacemaker, we would set the sensitivity in the middle, not too high and not too low. Because if you have the sense amplitude of 5 and you set the sensitivity set at 5 or 6, the pacemaker have to see the pacemaker could not see the intrinsic rhythm, because we usually compare the sensitivity threshold as a wall. If you set a threshold too high, the pacemaker could not see the intrinsic rhythm. So we have to set in the optimum of 3. The pacemaker can still see this rhythm, this part. But somebody would ask, why would not we set the why we did not set the threshold low? Why? Because if you set the threshold too low and there is some extrinsic activity outside the pacemaker that could cause some noise in the pacemaker. If the threshold, the sensitivity threshold is too low, the pacemaker would misunderstand, and they would understand that the noise is the intrinsic rhythm and that the pacemaker would not generate the impulse. And this could cause the patient some problem of syncope or the symptom from the pulse of the ECG. Okay, okay, with everyone okay with this topic, with this sensing function? Okay, I will move on to another terms that you need to know. It's called undersensing. The undersensing is the pacemaker that pacemaker could not see the intrinsic rhythm. This is the intrinsic rhythm of the patient, and this one is the number 5, the red line that I put in is the sensing threshold, and you can see that the sensing threshold is too high. The pacemaker could not see the intrinsic rhythm. This would call undersensing. So the undersensing occurs because the sensing threshold is too high. So what we can do is we decrease the sensing threshold from 5 to 3. We decrease the number, but we call it higher sensitivity.อันนี้งงไหมครับ? Okay, so start again. This one, the sensing threshold is at 5, but the intrinsic R wave amplitude is lower than 5. So the pacemaker could not see the intrinsic rhythm. This is called the undersensing. So we correct this problem by lower the number from 5 to 3. Lower the number, but the lower the number is called increase the sensitivity. This would the patient the pacemaker will now see the R wave, the intrinsic rhythm here. Anyone with any questions about this?
อาจารย์คะ like why it can't see the intrinsic rhythm if it's set too high?
The sensing threshold is too high. Like this one, the sensing threshold is the wall, this wall. the sensing threshold is the setting we set in the pacemaker. The sensing threshold means that the lowest number that pacemaker could see the intrinsic rhythm. So if you set the sensing threshold at 3, the pacemaker could see the intrinsic rhythm because the amplitude of R wave is more than 3. But if you set the sensing threshold at here at around 4, the pacemaker would not see the intrinsic rhythm because the sensing threshold is too high. So it's the same with this one. This one, the R wave amplitude is less than 5. Here, the R wave amplitude. But you set the sensing threshold at 5 millivolt, which is too high. The sensing threshold that was set is too high. So the pacemaker could not see the intrinsic, and this event we call the undersensing. So how can we correct this one? So we have to set the threshold lower. Set it to 3. So we lower the number, and after we lower the number, there is some intrinsic that pacemaker could be seen here. Okay, do you understand this?
Yes ค่ะ
Okay, but there's some tricky words. We lower the number of sensing threshold from 5 to 3. We lower the number, but we usually call increased sensitivity. From here, we increase the sensitivity of the pacemaker by lowering the sensitivity threshold. This sound might a little bit confusing, but we usually use this word. So this is another term. It's called oversensing. This is the intrinsic rhythm of patient, which the R wave amplitude is around 4. We set the sensing threshold at 1.5, which is quite low. And if there is something like this one, the T wave, which the pacemaker shouldn't see as the R wave, but you set the sensitivity threshold too low, the pacemaker would misunderstand that this T wave is R wave. So this is called oversensing. So how can we correct it? We increase the number of sensitivity setting from 1.5 to 2. So now the pacemaker could only see the R wave. The T wave could not be seen anymore, and the pacemaker could return to their normal function. Again, the tricky word. We increase the number of threshold, but we usually call lower sensitivity of pacemaker. Anyone, any question about this? It's the same as the last slide I mentioned, but in an opposite way. These two words is quite confusing, and we usually put it in a cardiology board exam also because people tend to confuse about these words. Okay, so sensing function, the undersensing means that the pacemaker could not see the intrinsic rhythm. So we decrease the sensitivity threshold, which we call higher sensitivity. The oversensing is that the pacemaker sees other things that we don't want to see. For example, if the sensitivity threshold was set too low, the pacemaker would misunderstand the T wave to R wave. So we could fix it by increase the number of threshold, or we call lower sensitivity. Okay, this is the table below is the acceptable sensing value, or we can call it acceptable R wave amplitude and P wave amplitude. During the acute phase or after the implantation, the P wave should be more than 1.5 or around 1.5 to 2. The R wave, the acceptable R wave after acute phase is more than 7. And in the chronic phase, the acceptable P wave is more than 1 millivolt, and acceptable R wave is more than 5 millivolt. Okay, so we have understand all the terms. So now we are going to apply it to a single chamber pacing. The first question I want to ask you is, what is the mode of this pacing? Can anyone answer this?
I think this pace in V.
Yeah, there is V. Okay. And what is the sensing?
V ค่ะ
Okay, ครับ Yes, it is sensing V because you see that there is a QRS here, and the pacemaker does not pace on this QRS or near this QRS, so it could sense V. And what is the response? After it see this V, it does not pace. What is the response?
I ค่ะ
Okay, you get it right. It is VVI because it see this and it inhibit itself. Okay, the next one. What is the pacing site?
V ค่ะ
Correct. It is V because you see the pacing here in V. And sensing, what is the sensing? Okay, it's a bit hard because I will give you a clue. You see this one, two of this and this is intrinsic rhythm, right? And the pacemaker still pace at the same rate. If it could sense this ventricle, it should pace later than this one. This RR interval is the same. This one and this one. It means that the pacemaker could not see this intrinsic. It should be O. It could not sense anything. If it is V, the pacemaker should sense this one, and it would delay the spike. Furthermore, to this, the duration between this one and this one should be the same. This one and this one should be the same. So this pacemaker could not sense the intrinsic rhythm. The sensing is O. And also the response should be O because it could not sense. So it could not respond to sensing. Do you have questions about this one? I could compare it to this one. You see this one, this one, you could tell that the pacemaker could sense this V because the RR interval between this R and this R is the same as RR interval from this to this. Because the pacemaker senses the intrinsic R and it delays itself to the program rate งงไหมครับอันนี้
เอาอีกรอบนึงได้ไหมคะ
ได้ครับก็คือokay usually usually we program the pacemaker at one rate for this one we program it in like around 60 beat per minute so if there is some sensing occurs like this QRS complex the pacemaker senses it so it inhibits itself not to pace but after this intrinsic come if there is no second intrinsic at the lower rate we have programmed the pacemaker would pace so we know that this QRS is sensed because the duration between the intrinsic QRS and the pace QRS follow this one is the same as the rate between the pace QRS this one คือเรารู้ว่ามันเซนเพราะว่าปกติสมมุติว่าถ้ามันเซนถ้ามันเซน QRS ของ Intrinsic แล้วเนี่ยเราตั้งเรทไว้เท่าไหนอะเครื่องมันจะต้องเพสให้ได้เรทเท่านั้นเหมือนเดิมก็คือพอมันเซนตัวนี้ปุ๊บบอกว่าเครื่องตั้งเรทไว้70เซนตัวนี้ปุ๊บมันก็จะรอไปกระทั่งมันครบว่าไอเรท70มันมาตรงไหนตัว Intrinsic มันควรจะมาถ้ามันไม่มามันก็จะเพสมันต่างจากอันนี้อันเนี้ยเราตั้งไว้เนี่ยเรทเนี่ยก็น่าจะประมาณ70เหมือนกันแต่ว่าแทนที่ถ้าเกิดว่ามันเซนส์ตัวนี้ได้เซนส์ Intrinsic ตัวนี้ได้มันควรจะรอจนกระทั่งครบเรท70แล้วมันถึงจะเพสขึ้นมาแต่ในกรณีอันเนี้ยมันไม่รอเลยเห็นไหมมันไม่สนใจเลยมันอยู่ๆมันก็เพสมันเพสขึ้นมาโดยที่ตัวนี้กับตัวนี้ก็เรทเท่ากันตัวนี้กับตัวนี้ก็เรทเท่ากันเพราะฉะนั้นน่ะแสดงว่ามันไม่ได้เซนส์ Intrinsic ตัวนี้เลยอันนี้เข้าใจไหม
เข้าใจแล้วค่ะ
Okay, I will speak about this in English again. We say that the pacemaker did not sense this QRS because if the pacemaker sent this QRS, it would delay until the lower program rate until it pays the output out of the pacemaker. This one, it does not delay. It's still pacing at the same rate before. So we conclude that the pacemaker did not sense the intrinsic QRS. So it should be O in the sensing. And if there is no sensing at all, there cannot be any response to sensing. So it should be O again in the third name of the pacemaker. Okay, if you don't understand anything, you can ask me directly. Okay, so we move on to the next one. This is the diagram how to program the pacemaker. There is two modes of programming. One is fixed rate pacing, and second one is demand pacing. The fixed rate pacing is that you don't care about the intrinsic rate. You don't need any sensing. You just pace at the rate you want. So there is two types the single chamber that put only the atrium in the atrium is called AOO. And another one is the put in the ventricle is called VOO. It's OO because the sensing, you don't need the sensing because you want just only a fixed rate. And if you don't have sensing, you don't have a response to sensing. So it is OO. It is a synchronous pacing because you don't see any intrinsic, you just pace as you want. It is rarely used now because there is some risk of pacing onto P wave or T wave, which could induce an arrhythmia. Because the pacemaker don't care about the intrinsic rate, so when they pace, there's a slight chance that the pacing spike would be on the T wave, and this would create what we call an R on T phenomenon, which could lead to ventricular tachycardia. This type is only used as a magnet rate. If you can remember from the last session that there is a leap switch in the pulse generator that would respond to the magnet. Usually the magnet rate is programmed as a fixed rate, a VOO or AOO. We use this magnet rate during the operation that we think the operation would cause some noise or some extra activity that would cause a problem to the pacemaker. The second mode is the demand mode. Demand pacing, which means that you only pace when the patient needs. So we need the pacemaker needs to see the intrinsic of the patient so that it could decide to pace or not to pace. There is two types of single chamber, and single chamber with inhibited pacing and single chamber with trigger mode pacing. Usually nowadays we use the single chamber with inhibit pacing almost all the time. It's called AAI if you put the leads in only atrium, and it called VVI if you only put the leads in ventricle. It also there is a multi-programmable. There is a lot of function in this type, and also we could add the fourth number of the pacemaker or the rate response into this type of pacemaker with the rate response feature or the rate modulator. The another one is single chamber trigger mode without an inhibition. This is not the D, only trigger. It is used. It will pace when you sense the intrinsic. If there in AAT, if there is an intrinsic P wave that the pacemaker could see, it would pace every time on the intrinsic event that is sensed. In this type of pacemaker is not widely used nowadays. In the past, we used it to prevent an inappropriate inhibition from oversensing. This means that if there is some oversensing, the pacemaker would trigger itself and pace to prevent an unlawful event from the oversensing. By the way, anyone don't understand anything about this type of pacing? Okay, so if there's no question, I will move on to another slide. This is the VVI pacing. you can see that the first one is pacing with capture ventricle. And the second one is the intrinsic. So the pacemaker sends the intrinsic and it inhibits itself not to pace. Usually if there is no intrinsic here, the pacemaker should pace here with the pacing interval we set. But if the pacemaker sends the intrinsic here, the pacemaker would change the interval, would count the new interval from the sense wave to here. This is the same as I described it before. And if it is pace and no, there is this is another pace. The pacing interval is reached and it pace and capture. And this one also would wait until the pacing interval is reached. And if there is no intrinsic, it would pace again. But if it is intrinsic somewhere between here, it would count a new pacing interval from here to a same duration here. This could call the duration from the intrinsic rhythm to a new pace rhythm could be called in other terms as escape interval, which is the ventricular sense event to the pace event. But the duration between the escape interval and pacing interval should be the same. Any question regarding of this slide? Okay, if there's no question, so we can move on. Okay, the upper one is this is the atrial pacing, the AAO and AAI. The atrial pacing here is this is the atrial spike, which is capture atrium, and there's an interval between two pacing spikes that we program is called pacing interval. And in the lower ECG, there's a pace spike and a capture atrium, which conduct to the QRS, and there's some intrinsic come out, and the pacemaker sends the intrinsic. Then it changed the pacing interval into the new one from count from the intrinsic here to here with the same duration as pacing interval that we have programmed, or we can call it in other terms an escape interval, the same as I mentioned before in that slide. So the pacing interval is from the atrial pacing to atrial pacing, and the escape interval is from atrial sensing to atrial pacing. Do you have any question? Okay. Other terms that you need to know is lower rate limit. Lower rate limit is the lower rate that pacemaker should pace, or we can call it a maximum length of time that the pacemaker circuit will wait for the intrinsic. both V or A activity to occur before pacing. So if the lower rate, if we set the lower rate at 60 beats per minute, after the pacemaker paced first beat, it would wait until the time the lower rate is reached, and if there is no intrinsic out of the heart, the pacemaker would pace. Usually we set the lower rate limits in, we could set it in rate as beat per minute, or we could also set it in interval or millisecond also. We use the same formula, the 60,000 divided by rate or divide by the cycle length to set this lower rate. There is some terms in the box here, both box, which is the same as the lower rate limit. Okay, so this is another term. This is what you have to understand after I have to describe this in the section in this section with the lower rate limit. This is the pacemaker that will set the lower rate limit in the yellow box. The pacemaker should be paced at the end of the yellow box, but it did not pace. It wait furthermore until the QRS, the P and QRS complex has come. This one is what it should look like. It should pace here. But from that example, it did not pace. What could happen in this pacemaker, assuming it is a VVI? Can you answer me? Okay. If you see this event, you have to differential diagnosis two things. One is that is there any problem occurs with the pacemaker? We already programmed the lower rate limit here, but it not pace. Something might be wrong. The pacemaker failure or something. Or another thing that you should think of is that is there any spatial mode that could extend sometimes after the lower rate limit have reached? Yes, it's called the hysteresis interval. This is one of the modes that were used in the single chamber pacemaker to promote the intrinsic rhythm. Because the inventor of the pacemaker, as we know that if patient gets the intrinsic, it would be better than the pace rhythm. So the pacemaker companies try to promote the intrinsic rhythm by adding this function in the single chamber pacemaker. Pacemaker with this hysteresis function could wait further than lower rate limit in what we call a hysteresis interval until the end of hysteresis interval. If there is an intrinsic activity came out of your heart, it's okay. It would not pace. But if it's the end of hysteresis interval, there is no intrinsic rhythm. The pacemaker would pace out. So don't sometimes so don't be too excited if you see something like that. If you have some patients who is on the VVI and the lower rate program at 60. But sometimes you see that there is some beats that the rate is lower than 60. You should check if the pacemaker have this type of function or not. If the patient pacemaker has this function, it would be okay to follow up. It's a normal thing. It's a normal function. But if the pacemaker doesn't have a hysteresis rate or hysteresis mode, you should raise some awareness that there's really something going on. And if the hysteresis interval have reached and there is no intrinsic rhythm at one time, the pacemaker would continue to pace at the lower rate again. Okay, so I come to the question, what mode does VVI pacemaker change to when a magnet is applied? Can anyone answer this?
Might be VOO.
Okay, so you get it. If you apply the magnet into the pacemaker, it would switch from demand mode into fixed rate mode. So it should be VOO. Okay. So I'm going to talk about the magnet mode. The magnet mode you apply on the pacemaker and it should change to fixed mode or so-called the asynchronous mode. What benefit from the magnet mode? The first one that we can access is to access the quick assessment of capture, because you change to the fixed mode and the pacemaker would only pace and you can access the capture from there. The second one is you may be correct the oversense. By applying the magnet, it should switch off every sensing function, and this could correct the oversense because the pacemaker would not care about the sensing and it would only pace. And another benefit of magnet mode is you can access that is the output being delivered to appropriate chamber. Because if you have a dual chamber pacemaker, you put a magnet mode in, the pacemaker would also change to DOO. So there would be a pace spike in both atrium and ventricle leads, and that would give you an opportunity to access if the A pace followed by P wave or not, and the V pace spike followed by the QRS or not. If you have some kind of dislodge or there is some switch of the RV lead into RA lead, if you put the magnet in, you might not get the pace capture of the ventricle. If no output during the application of magnet, number one, magnet is in a proper position, insufficient strength. You put the magnet, not the you misplaced the magnet. You didn't put in the right position. If you put the magnet on the pacemaker and did not have an output again, maybe it's because the reed switch stuck in opening position. It's about the reed switch problem. The reed switch which was used to sense the magnet was not working properly. The third one is that the battery depletion. If the battery is low, the magnet mode would not be activated. An open circuit or lead fracture. You put the magnet mode in the pulse generator. The pulse generator changes it into asynchronous or fixed mode. but there's no output because the lead was fractured. No output can come out of the lead. And number 5, the non-functional device. The device was failure. The pulse generator was broken and it does not respond to any magnet. Magnet response can be programmed on or off. Some of the pacemaker, if you program the magnet response off, you won't see anything if you put a magnet on the pacemaker. You have to be aware that a magnet function in each type of device has a unique rate and model response. And type of response may be programmable on the pacemaker. We should not think that a DDD device will exhibit a DOO response if you application of magnet mode. Because of the reason I mentioned above, that each device has unique rate and function and model. Before you applying the magnet mode to the patient, you should talk to the company, or you should see the program of the device before you put in. But usually it is OO mode. But be aware that some device might not, maybe at the implantation the operator might change something in the magnet mode. Okay, so back to this patient. This patient has you see this is called a noise or a myopotential inhibition. This one, his pacemaker is oversense this noise to a wave, and it does not pace properly, because if it pace, the pace spike should be here. So we apply the magnet mode. We switch off the sensitivity function so that the pacemaker would pace at a proper time, not caring about the sensing. Okay, just finish with the single chamber pacing. We will apply we will go on to the dual chamber pacing. So there are 4 states of dual chamber pacing. This is the 4 state that we could have. From in the atrium channel, we could have A sense, V sense. This is what we can see in the ECG of the patient who have implanted with dual chamber pacemaker. If it is A sense and V sense, it is intrinsic rhythm of the patient. It can be A sense because atrium intrinsic comes and the A lead is only sense, but the intrinsic of ventricle does not come in the proper time, so it could be V pacing. The third one that we could see is that the atrium intrinsic does not come, so it is an A pace, but the ventricle sensing has come, it is V sense. And the last one is A pacing and V pacing because there is no intrinsic at all. This is 4 states that could be seen in the ECG of patients who was implanted with dual chamber pacemaker. The intrinsic event of P wave is A sense, the R wave was V sense, the pace event is A pace, and the pace event of V is V pace. In a dual chamber with a DDD mode, as I mentioned before, the DDD, the third D, is a tracking mode. So we have programmed an atrial tracking or AV interval or AV delay as a fixed number for the pacemaker to track between atrium and ventricle channel. This interval is called a VA interval or atrial escape interval. It is a interval between the R wave and P wave, R wave here and P wave. This is called VA interval. The interval between ventricle to atrium. And another term that you need to know is the AA interval. It means atrium to atrium interval, or you can call it a lower rate interval again. So in dual chamber pacemaker, the lower rate interval is determined by the atrium channel. Anyone has any questions about this? This you might have to remember and recall it, because when we program the dual chamber setting, we need to program this interval. First one, AV is the time from atrium to ventricle, which is programmed for the atrium to be tracked by the ventricle signal. And this VA is from ventricle to atrium interval, and the AA interval is the lower rate. So if the patient was programmed AA interval or lower rate at 60 beats per minute, if he was implanted with this pacemaker, the lower rate that he could obtain is the 60. He shouldn't have any lower than 60 beats per minute. The AV interval plus the VA interval is equal to the AA interval and is equal to the lower rate interval. We could program the lower rate interval and the AVI interval. Okay, so this is I will explain by this picture for you to understand it. The pacemaker from the RA leads, and the pacemaker generate the impulse from the right atrium, and this lead to P wave, and the signal travel along the atrium into the AV node. This is called AV interval duration. And after pass the AV node into the ventricle, there is a spike wave in the ventricle because the RV leads generate the impulse by tracking the AVI interval. Any question regarding of this? Okay, so this is the same ECG that I put it in the start at the start of the session. So what is the mode of this patient? You have one answer that it is DDD, but it could be another type of pacemaker. Can anyone answer this?
DOO.
Okay, it is the OO or DDD. โอเคครับถามได้นะถ้าใครไม่เข้าใจ any question regarding of the interval that I have mentioned. Okay, if nobody is answer anything, I will move on. And what is this? What is the mode of this?
I think it is a pacing.
Okay, a pacing. Okay. What about sensing?
A sensing.
Okay, it can be a sensing, and it also can because we don't see any intrinsic P, maybe it is no sensing at all. It's okay. It could be AOO because you see only all sensing, all pacing here, or it can be a sensing AAI. Okay. And another mode that it could be, can anyone answer me? You see this QRS complex. You don't know if it is V sensing or not. Is that correct? It could be because there is a RV lead also, it could be V sensing. Or if there is no RV lead at all, it could be AOO or AI. So if there is an RV lead in here, it should be 2 leads in the pacemaker. So it should be D. And it can be D also. As I have said before, if it is D, there is atrial pacing here, which cause a pace, and there's intrinsic ventricular rhythm. So the V can sense. There must be lead in ventricular channel. So it could. So if there is a lead in ventricular channel, it also can pace. So it should be both D and D, and the response is also D because the P wave and QRS is the constant between the PR. So it means that the pacemaker could track between the P wave and the QRS เข้าใจไหมครับวันนี้
อาจารย์ช่วยอธิบายตรง sensing กับ response ใหม่หน่อยได้ไหมคะว่ามันจะรู้ได้ไงว่าเป็น sensing อันไหนกับ response อันไหนอะค่ะ
หมายถึงว่าsensing response อันไหนกับหมายถึงก็คือ sensing เนี่ยคือสมมุติอันนี้ถูกไหมอันเนี้ยมัน sense มันถ้ามันมีสาย V อยู่มันแสดงว่ามันต้อง sense QRS ได้ถูกปะเดี๋ยวกลับไปอธิบายใหม่เลยก็ได้แป๊บนึงจริงๆอันนี้จะจบละเดี๋ยว Okay, I will explain the sensing again. The sensing is what we is that the pacemaker see the intrinsic rhythm. If there is intrinsic rhythm and the pacemaker see it or not, it is a sensing. And the response to sensing is what the pacemaker do when the pacemaker see the rhythm. For example, from the last slide, we assume that we assume that if we assume that this patient is on the dual chamber pacemaker, he has an intrinsic ventricular signal. There is no pace spike of the ventricle, so we assume that the patient, the pacemaker see the intrinsic ventricular signal, and the response to sensing in this patient is not to pace, to inhibit. So the pacemaker inhibit the pacing of ventricular channel. So 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 the response is inhibit. But for the dual chamber, which has dual response, including trigger and inhibit, there is some difference because if the pacemaker also has a trigger response, you will see that if there is a P wave in front of QRS coming along, and it is stimuli to the RV leads, the pacemaker will respond by trigger itself and pace on the intrinsic. เดี๋ยวอธิบายภาษาไทยก็ได้อันนี้เดี๋ยวนะย้อนกลับไปก่อนไม่เข้าใจตรงไหนนะ
เหมือนหนูจะเข้าใจบ้างแต่ก็ไม่แน่ใจอะค่ะคือตัว pacing ก็คือเราจะรู้ได้ก็เพราะว่ามันมีตัวpacing spike อยู่ข้างหน้าใช่ไหมคะ
ใช่ถูกอันนี้ก็คือรู้ว่า pace ใช่
แต่ว่าตัวsensing มันดูยังไงอะคะดูว่าแบบยังไงว่าเป็นตัวไหนอะค่ะก็คือถ้าเกิดมันมีสมมุติถ้ามัน pace ที่atrium ก็คือจะต้องมี sensing ที่เป็น QRS ขึ้นมาอย่างนี้หรอคะของ ventricle
ไม่ใช่ก็คือถ้าเป็น atrium มันอยู่ในแค่ chamber atrium มันก็ควรจะ sense แค่ตัว P wave อย่างเดียวดู sensing ก็คือดูถ้า atrium ก็ดู atrium ถ้า ventricle ก็ดู ventricle อย่างเช่นตัวเนี้ยสมมุติว่าเขาใส่ dual chamber นะสมมุติว่าเรารู้ว่าเขาใส่ dual chamber ตัว QRS ตัวเนี้ยเราไม่เห็น pace ของ ventricle ถูกไหมแสดงว่าสาย ventricle มันต้องเห็น QRS complex ตัวนี้อันนี้ก็คือ ventricular มันต้อง sense QRS complex ได้อันนี้เข้าใจไหมคือเราเวลาเรา
ค่ะก็คือแบบว่าถ้าสมมติอันนี้เป็นแบบว่าเป็น dual sensing ก็คือมันสปายที่ A เพราะว่ามันไม่มี intrinsic ของ A แต่ว่ามันไม่สปาย V เพราะว่าตัว QRS มันเป็น intrinsic ใช่ไหมคะ
ใช่ถูกต้องก็คือ V มัน sense อันนี้ก็คือ A pace V sense ใน dual chamber คือปกติแล้วว่าในชีวิตจริงเราจะรู้ก่อนว่าคนไข้ใส่เครื่องอะไรถูกปะแล้วก็ค่อยมาดู EKG ทีหลังเราก็จะไม่งงว่าไอ้ EKG อย่างเงี้ยมันเกิดขึ้นได้ยังไงแต่ว่าในข้อสอบเขาชอบเอาออกมาถามแบบเอาสตริปอย่างเงี้ยมาถามแล้วก็ถามว่ามันเป็นแบบไหนได้บ้างซึ่งในคนเนี้ยมันมี A pace ถูกปะเพราะฉะนั้นมันจะเป็น atrium pacing อย่างเดียวก็ได้คือ atrium pace แล้วมันก็สัญญาณมันก็ไหลลง ventricle เป็น QRS intrinsic ก็ได้มันก็เป็น atrial pacing ที่เป็น single chamber ก็ได้เช่นเป็น AAI ก็ได้หรือว่าเป็น AOO ก็ได้ก็คือ AOO ก็คือเป็น fixed rate ก็คือมัน pace อย่างเดียวไม่สนใจแต่ถ้าเป็น AAI ก็คือมัน pace ก็ต่อเมื่อไม่มี intrinsic ถ้ามี intrinsic มามันก็จะ inhibit ตัวเองไม่ pace ก็ได้หรือว่าก็เป็น dual ก็ได้ก็คือมัน pace dual คือสาย A มัน pace แล้วมันมีสัญญาณไหลลงมา ventricle แล้ว ventricle มัน sense มันก็เลยไม่ pace ขึ้นมาอันนี้มันก็ยังเป็น dual chamber ได้เหมือนกัน โอเคไหมany questions again Okay, so if there is no further questions or if anyone want to ask anything, you also can email me or after the sessions. So for this is the first part of this afternoon, and we have another small part about ICD and CRT. Quite complex, but not. I don't think it's as hard as this one. So, do you want to take a break for 5 minutes before we resume the lecture?
yes ค่ะอาจารย์
Okay. So we see you in 5 minutes. Okay. โอเคพร้อมไหมครับ
พร้อมค่ะ
Okay, the next topic is the basic knowledge about the automatic intraconnect defibrillator and the cardiac resynchronization therapy. So the outline is this. Okay. As we mentioned it before, there were 3 types of ICD: the single chamber ICD, the dual chamber, and the CRTD. All of it has a pacing function. The pacing function is the same as I have lectured you before in the last period of the permanent pacemaker. So now we are going to talk about the therapy of tachycardia as the main subject. There is 3 types of therapy in the ICD: the bradycardia pacing, which is the same as permanent pacemaker; the anti-tachycardia pacing, or we can call it ATP; and the shock therapy. Okay, we usually treat the patient who experience ventricular arrhythmia with this type of device. The most common is ventricular tachycardia, which generates from the ventricle, and the ventricular fibrillation from the ventricle also. We use this device to prevent the further cardiac event after these 2 arrhythmia. If we can treat the patient right in time, the patient wouldn't have to experience any symptoms or wouldn't have to experience cardiac arrest at all. The first treatment of the tachycardia is called ATP programming or anti-tachycardia programming. It is a type of pacing which was used to terminate the VT or VF. It is a pacing. We usually the pacemaker usually pace at a very fast rate for 4 to 6 bursts or for 4 to 6 beats, and then stop to see if the VT or VF was terminated or not. This program usually used before the shocking therapy, because if you can use the ATP to terminate the arrhythmia, it means that you don't have to deal with the complication after the shock therapy. This is the example of the ATP to terminate tachycardia. This zone is the VT, approximately rate 207 beats per minute. This is ATP burst. When the device detects the ventricular tachycardia, it would trigger the ATP, and the device would burst pacing 6 beats or more if we program it. After we burst the pacing, the ventricular tachycardia terminate and return to normal sinus. This therapy is more gentle to your cardiac muscle cell than to shock or to cardioversion. As I said before, the ATP use a sequence of rapid pacing pulse to terminate the tachycardia. The advantage of the ATP is it is painless. The patient wouldn't know what the device do. He wouldn't recognize the ATP. No charge time. It is opposite than the shock. The shock needs power for like 37 joules, so it needs a charge time to reach the power before it delivers the shock. But the ATP does not need a charge time. It uses only little battery energy and can be delivered before the patient is symptomatic. The disadvantage of ATP is that it is not as always effective as the shock. If it is ineffective, it would delay the patient's getting effective therapy. If we program the ATP before shock and we use the ATP in the VT that does not respond to pacing, it may delay the appropriate therapy. And the last one is, in some types of VT, ATP could accelerate the rate of a VT, and this could cause a clinical deterioration. There is a terminology in regarding the anti-tachycardia pacing. Stimulus is a pacing pulse in ATP. Burst pacing is the delivery of rapid sequence of stimuli in a same cycle length. For example, if you burst pacing at the rate of 180 beats per minute, every beat that comes off the pacemaker during the ATP would be the same rate. There's some burst cycle length. This is the you can program the cycle length same as the rate. Another term in the ATP is ramp. Ramped is similar to burst, but ramped is when you pace with faster rate, with shortening interval within single bursts. Like if you pace with the first burst at 360 millisecond cycle length, the second beat may be 340, 320, and 300. This is called ramp. Ramp means pace burst ATP with faster rate in one set of ATP. Scanning is a progressive shortening the burst cycle length with each burst. This means that you have one burst of rate 320 for 5 beats, and the second burst is shorter, maybe 300 millisecond for 5 beats. This means this called scanning in a different set of bursts with a different or shorter cycle lengths. Train is a series of bursts. Train means that you may have 3 sets of bursts in one train. This is just a terminology. You may not use it all, but you have to know the terms. This is ramp. Ramp is when you have each pace you pace in a shortening cycle length. This is ramp. If it's a burst, it would stay in like a 360 all of the beats, the pace. And this is one set of burst or one set of ramp. This is a scanning. As I told you, the scanning is many set of bursts, but every set have a shortening cycle length. The first set has every pace beat has cycle length of 360 milliseconds, but the second set has 350, and the third set have lower the cycle length. This is scanning in action. What is different between the ramp versus burst for the fast VT termination? This is the study in the year 2009. It compares one single burst versus one single ramp in 206 ICD patients. The effective of burst seems to be higher than the ramp for 75% and 54% to terminate the fast VT. So this study concludes that ATP reduced ICD shock. A single burst is more effective than a ramp to terminate the fast VT. So nowadays we usually program burst more than ramp because of many studies with the same result as this study. So how can we program the ATP. For slow VT, we can use multiple ATP, each either on 5 to 15 beats per set. Because the slow VT would cause less hemodynamic unstable, so we can use the ATP for such a time before we have to go further to the shock. For fast VT, we only allow a single ATP before go to shocks. And for the VF, usually VF does not respond to the ATP, but there is some time for wait for before the shock that the pacemaker have to charge the power. So we could program the ATP during charge before the shock would occur, and when the charge was finished, we stop AAP and we shock the patient with the defibrillator. Again, the benefit of ATP is to reduce the shock and the consequence of the shock therapy. The second therapy of the AICD is the defibrillation therapy or shock therapy. It is aimed to interrupt the abnormal re-entry. This one, we have to remember that only the re-entry mechanism of arrhythmia could be terminated with the shocking. If the mechanism of arrhythmia is not re-entry, for example, automaticity, it would not be terminated by the shock. But the most of the VT and VF are re-entry, so almost all of it would terminate with VT, with shocking or with defibrillation. The basic of shock is to for the VT or VF, each cell in the heart is at a different stage of action potential. So it is erratic, and the electrical of the heart is chaos during that time, and it is unsynchronized for the tissue to pump the blood out. So we apply a high energy shock to reset all the cell, to restart it to the same stage of the depolarization. And when every cell was reset, the ventricular arrhythmia would stop. An effective shock must capture every cell because we want to reset all the cells. And to capture every cell, they require a large bolus of energy with 29 to 36 joules delivered quickly in 5 to 10 milliseconds before the patient's collapse. There is types of shock that you need to know. There's a term. The first one is cardioversion. It means synchronous therapy. But for ICD may refer to less than maximum energy shock for VT. Cardioversion usually means that you have to synchronize the shock with the QRS complex. It usually used in supraventricular tachycardia when you need to shock. This term are not usually used in a permanent intracardiac defibrillator as we are speaking, but you have to understand it. The cardioversion means that you have to synchronize with the QRS complex before you apply the shocking therapy. You would likely to see this in external defibrillator that's used in the ward, not usually see in the implantable device. The second term is defibrillator. It is non-synchronized therapy. It means that we don't need to synchronize it with the QRS complex of the patient. We can deliver the therapy anytime we want. The defibrillation is required for VF. The VT can be treated with virus therapy, can be treated with ATP, can be treated with cardioversion in some types of VT, and also can be treated with defibrillation. Anyone confused about these terms? You can ask. Or do you have any sessions regarding of the external defibrillator? Okay, if there is no question, I would go further. Okay, as I mentioned before, if you apply the electrical shock to the patients, there would be some effect to the patient because you apply a high power into a patient heart. So the worst thing is that there is some myocardial injury, and some some patients might not have any effect at all. But if you repeated shocking the patient, there must be some myocardial injury, or maybe there is a induction of fibrillation, which is a R on T phenomenon. It is occur when you put power into the heart on the duration of T wave on this ECG. You accidentally put the power in that duration, and this would cause further malignant arrhythmia such as VT or VF. So to prevent this kind of adverse event, the induction of fibrillation, you may need to do a synchronization cardioversion instead of defibrillation in some type of arrhythmia, for example, in SVT or in pulse VT. Okay, but all you need to know in this slide is that electrical shock have some kind of harmful event to the patient if it is repeatedly shocked. The thing you need to know about shock therapy in ICD is the shock vector and polarity. There is two types of ICD leads. The first one is single coil. Single coil is there is only defibrillator on the end of the lead. And the second one is dual coil ICD. Dual coil have two defibrillator, one in the proximal part of the leads and two at the distal part of the leads. The single coil use the vector from the positive vector from the coil to the negative vector at the pulse generator. There is reverse polarity. The positive polarity is on the pulse generator, and the negative is on the coil. And the dual coil have the positive charge in both coil and the negative charge in the pulse generator. So the difference between the single coil and dual coil is that single coil can only shock in one vector. Here is the vector. Only one vector here. But dual coil can use two vectors, one here and two here. It was assumed that the dual coil would cover more of the cardiac cell, cover more of the heart, and would effectively shock than the single coil. But in the real world study, it is no different. The effective therapy is not different between the single coil and dual coil. So when you implant the ICD into the patient, there is some concern raised that the shock delivered by the ICD may lead to adverse prognosis and increased incidence of heart failure. This is the patient with shock burden and mortality. You can see that there is the Y plane is the survival, and the X plane is the year of implant. Patients with no shock have more survival time than the patient with shock, with the ICD shock. This means that if the shock burden is high, it increases mortality in patients with ICD. So we need to prevent everything. We need to do everything to prevent the shock therapy. I mean, the shock is a good therapy to treat VTVF, but if the patient has too many shock, it would increase incidence. The best way to treat these patients is to prevent them not having VT or VVF at all. This is the prognosis importance of defibrillator shock in patients with heart failure in SCUT-HEP study. You can see that the patient with more shock would have more hazard ratio than the patient with no shock. Like you see in the forest plot B, with 2 or more shock, they have higher mortality hazard ratio than with no shock. And if the patient has more shock plus inappropriate shock, the patient have even higher hazard ratio for this. I'm going to explain this one. Inappropriate shock means that the defibrillator gives the shock therapy in patient who doesn't need a shock. Maybe the defibrillator has false noise or some external noise that interfere with the function, and it delivers shock because it misunderstands that the noise is VTVF. This is called inappropriate therapy. Or the defibrillator see other rhythm that don't need to be shocked, such as atrial fibrillation, and it's misunderstand with the VT and it gives a shock. This is called inappropriate shock, which is increase the mortality of patient also. Okay, so this is all about the tachycardia therapy. Anyone has any questions before we go on to the knowledge of cardiac resynchronization therapy? Okay, if there's no question, I would like to continue on. So the next part is I'm going to talk about the basic knowledge of the CRT. This is when we speak about the CRT, we usually think of patient with heart failure because it is all of the patient who receive CRT is the patient with low ejection fraction of CRT. There is some other indication that we put the CRT in the patient, but those indications is only account for small amounts of patients. When we speak about CRT, this is speak about heart failure. This is the natural history of heart failure. You can see that almost all when the heart failure is a disease that is very severe with even low LVEF, and if the patient has more severe symptoms, it explain the New York Heart class. If the class is higher to 3 or 4, the survival is very, very, very low, and the hospitalization is going up if the patient symptoms is worsening from class 1 to class 4. And the commonest mode of death in patients with heart failure is sudden cardiac death and heart failure, and also heart failure itself. There is some theory explaining that these patients with heart failure, reduced EF, have what we call a desynchronization of the right and left ventricle. This is the normal conduction of normal heart. We have a conduction via the SA node down to AV node, and both to left and right ventricle in a similar time, in a same, almost the same time. So the QRS that we obtain is a narrow QRS less than 120 milliseconds. But in the patient with dilated cardiomyopathy, the heart is dilated. The left heart, usually the left heart was dilated. So the impulse conduction from the SA node to AV node would delay in the left bundle branch because the left heart is so big and dilated and slower than the right heart. So the ECG would be resulting in Y QRS complex and left bundle branch pattern. And also in some patients, if the right heart is also dilated, we could see that there is a Y QRS complex with also right bundle branch pattern. I have spoken this early in this morning that we put the CRT in. We put 3 leads in the RA, RV, and LV to generate the impulse and contract all those ventricle and atrium in the same fashion to reduce the dyssynchrony and to increase the cardiac output. So this is again the indication for the patients who who are benefit for the CRT. The patient with very low EF, lower than 35 minutes, sinus rhythm with a very wide QoS complex, more than 150. This means there is a lot of dysynchronous. A left bundle branch block pattern is more likely to benefit than the non-left bundle branch. And also, you can put the CRT in patients who have QRS wider than 130. And also, other thing that I have to mention is that the sinus rhythm, patients with sinus rhythm is more likely to be benefit with CRT than the patient who have atrial fibrillation, because the AF has a regularity in the rhythm. It is quite hard for the device to function properly in the fashion of a regular rhythm. So in sinus rhythm, patients tends to benefit more than in AF. And its contraindication in the QRS duration lower than 130 milliseconds, because the less duration the QRS, the less dyssynchrony, and this patient might not benefit or might not need the CRT. This one I have already talked about. And this is the proven benefit of adding CRT to ICD in heart failure patients. The CRT would give the synchronicity, increase the cardiac output. It would improve quality of life, increase 6 minutes walk distance, improve the functional class, and also improve the peak VO2 and treadmill exercise time, improve cardiac structure and function. It decreased the days of hospitalization. And the most important thing is that the CRT improve mortality of the patients and also improve combined mortality and hospitalization over medication. So if the patient has indication for CRT, it would lead to less death in this group of patients. The follow-up of the CRT typically performed 3 to 4 times per year, or 4 to 6 months. For in the guideline, they usually perform the follow-up for 4 months or 3 months. But in Thailand, in clinical setting or in some hospital with a lot of patients, some patients have to check the CRT like biannual per year, not as frequent as the guideline recommend. There is follow-up checklist. You review the measure data from the programmer. You measure you see the alert message. The alert message is when you have some malignant arrhythmia such as VT or VF, it will be stored in the device. Or when you have some kind of therapy such as ATP or shocking, this event will store in the device and it would come up with an alert message. You need to take careful attention with this alert message and see if it is true malignant arrhythmia or it is inappropriate or appropriate therapy. You see the episodes and diagnosis data. You test the capture the sensing threshold of the device, and you program the optimum, and you review all the program and review the clinical status of the patients, and you optimize all the program. And at last, you need to print the report and document all the event from the device that you have already checked. This is the interface of the programmer. This one, you can see that on the left side there is two alerts. This one would report that you have some kind of malignant arrhythmia, or you have a therapy that have been done in the past few days or in the period that you didn't come to check. And on the upper channel of the screen, you see this one is the intracardiac electrogram, a real-time intracardiac electrogram of the patient. You can see that it is some labels for you to see that it is atrial sensing and V pacing. If it is CRT, it would be biventricular pacing. It would write in B and V if it is CRT. And on the channel, the green channel here is the battery time. It will tell you that how long the battery is still last. This patient has longevity of 3.6 years. And if the green bar is less than this one, the ERI, it means that you need to change the battery of the generator. The patient, this is a term, it is called an ERI time. It's the acronym from elective replacement interval. If the bar is less than it's inside the elective replacement interval, this means that you need to change the pulse generator or you need to change the battery of the device. And this one here, you use when you perform a test involving capture threshold, sensing threshold, sensing value, and the lead impedance to see if there is something wrong. You see the trend from the last follow-up and you compare to the test in this follow-up. And here again, you see that this is VT and VF episode. This is similar to the other. This one tells you that the patient has experienced the VT or VF. Or if you go inside this window, you will see the event. You will see all the electrogram and all the details. Okay. So this is just for the example of the. This is the programmer of ICD. If it is a programmer of pacemaker, they wouldn't have a tachycardia zone configured and VTVF. They would only have sensing, a capture, and other mode that there is no shocking mode. So take home message for this topic is that the automated intraconnect defibrillator has 3 functions. They have bradycardia pacing like a permanent pacemaker. They could deliver therapy in an anti-tachycardia pacing, which you can program as a burst pacing or a ramp pacing. It could deliver shock therapy. And the last one is that optimal cardiac resynchronized therapy, including selection of patients according to their clinical and a good implant and program of CRT would benefit in improved symptoms and mortality of the patient to get a biventricular synchronization contraction. I didn't dig deep into how to program the CRT because I think at this moment it would be too hard for you. And for the last session about pacemaker, there are also a complex pacemaker timing that you may need to be learned later. But I think for now it is you should for it is the basic that you should know before you going to study deeper in that topic. Okay, so this is the end of this session. Does anyone has anything to ask? Please feel free to ask me. มีอะไรจะถามไหมเอ่ย
อาจารย์ครับ
ฮะ
Can you explain one more time pacing sensing แล้วก็แบบ
โอเค
จะอธิบายมัน detect ยังไงครับแบบ sensing อะไรอย่างเงี้ย
detect ยังไงล่ะครับ
ใช่ครับใน ECG tracing ครับ
เดี๋ยวมีอีกอันหนึ่งให้โชว์แป๊บหนึ่งนะ Okay, you have to separate into two types of the work. The pacemaker would work in 2 modes. One is pacing, and another one is sensing. The pacing means that the pacemaker deliver the output, deliver the electrical activity into the patient myocardium to capture the myocardium and depolarization. And another one is sensing. Sensing is when the pacemakers what the pacemaker see. Sensing is what the pacemaker see. If the pacemaker see intrinsic rhythm, this means the pacemaker could sense the intrinsic rhythm. Okay. Like this one. This is the intrinsic rhythm. If the pacemaker could sense the intrinsic rhythm, it means that the pacemaker sees the intrinsic rhythm and the signal sent back into the pacemaker, and the pulse generator will evaluate what the pacemaker should do next to the heart of the patient. Like this one. Like this one, assuming that this patient is implanted with dual chamber pacemaker. So he has one lead in RA and another lead in RV. We look at the RA lead first. The patient has pace spike before the P wave. This means that the RA leads is actually pacing. The RA lead is pacing, but if the RA lead is not, if there is, assuming that if there is an intrinsic rhythm coming up here, and there is no this one, that if there is an intrinsic rhythm coming up here, and there is no pacing coming up next, it means that the atrial lead sends the intrinsic P wave rhythm. It sees that there is an intrinsic P wave, so it does not have to generate the impulse because patient already have the P wave. This is the sensing function. Sensing is what the pacemaker see. อันนี้เข้าใจไหม
เข้าใจครับอาจารย์
โอเคนะ อันนี้เข้าใจนะ
เข้าใจครับ
If
I have one another question. If the
okay.
pacemaker sees the intrinsic rhythm of the myocardium of the patient, right?
Okay.
So it will not deliver the new signal, right? It will not pace the new signal.
Okay. Yes, it
So-
is. If the response is inhibit, it will not
Generate the-
deliver generate the rhythm. Yep.
And if it senses an abnormal abnormal electrical signal coming, right? So it will evaluate that signal and will trigger the normal signal, right?
You mean the abnormal signal, you mean like it's not from the heart or something, right?
From the heart ครับอาจารย์
From the heart. What abnormal signal do you mean?
Like the morphology of P wave, like something we have problem in after implanting the pacemaker, right? Is in case any complication happens in the heart, right? So in that case, it will trigger, right? Like it will sense the incoming signal, and it will.
Okay. If the abnormal P wave coming into the pacemaker, and it could be sensed, it might not generate the pacing. The pacemaker cannot tell that this is normal or abnormal P wave from the morphology. It could only tell that it sees or it not sees. เข้าใจใช่ไหม
เข้าใจ
It's not that smart. It's only know that this is P, and it's only know that it's P or it's not, but it cannot difference between the morphology of the P wave.
แล้ว trigger กับ inhibition มันต่างกันยังไงครับอาจารย์แบบใน ECG paper
trigger ก็คือ inhibit is when you see the intrinsic end, it does not generate the signal of the pace. But if it is a trigger, if they see the intrinsic here, so assuming that this is P wave and this is QRS, and you have a lead in an atrial, the trigger means that if the pacemaker sees this one, it will pace on it. So we don't usually use this mode anymore. We use this mode, as I mentioned earlier, that to terminate some type of tachycardia. So for example, if there is some really fast atrial tachycardia, and we program the pacemaker to trigger when it sees a fast rate of P wave, the pacemaker would if the pacemaker sees this P wave, it would trigger the pace and try to terminate this arrhythmia. เข้าใจไหมหมายถึงว่ามันเห็นพอมันเห็นตัว intrinsic แล้วมันก็เลยเพสทับขึ้นมาบนตัว intrinsic มันไม่ได้มีประโยชน์ในการรักษาแบบ bradycardia เลยไออันเนี้ยเพราะว่าถ้ามันมี intrinsic แล้วมันไม่ควรจะมี bradycardia ถูกไหม
ถูก
อันเนี้ยคือมันเหมือนกับมันตั้งไว้เพื่อสมัยก่อนนะเขาเอาไว้ป้องกันการเกิดอะริทเมียบางอย่างแต่ว่ามันพูฟมาแล้วว่ามันไม่ค่อยได้ผลนะเขาก็เลยไม่มีใครใช้เลยตอนนี้
ครับอาจารย์ขอบคุณครับ
Okay do you have anyone has any questions or if you want to ask me later after you have studied further, you can email me. My email is maybe you can write it down nitihi@nmu.ac.th. Okay. If you don't have any questions to ask, so I think that's it for today. I hope you have gained something, and I will see you in the next sessions about the intracardiac electrogram and arrhythmia, maybe next month. Okay, thank you very much for your attention, everyone. Okay, งั้นจบเท่านี้นะครับ
ขอบคุณค่ะ
ขอบคุณมากค่ะอาจารย์
สวัสดีค่ะ
สวัสดีครับ